Thanks very much, Melissa, and thanks to those of you who are spending your time at lunch to learn a little bit about cardiac evaluation of the pediatric athlete. If you can't hear, just let Melissa know and she can contact me and I can adjust the volume or anything else. I think it's the right time of year for considering evaluation of the pediatric athlete. In the spring, as we go into summer, a lot of pediatricians are being asked to clear patients for sports. Okay. Now, okay, there we go. So what about healthy students? It's pretty rare, but the outcome can be devastating. This typically occurs in healthy asymptomatic children and young adults and affects a disproportionate amount of attention from the school system and the media. Here's a couple of famous players from our area from about 2 decades ago. I was actually involved with both of them in my career. First is Reggie, who played for the Boston Celtics. Obviously, that was on. And then on the right, those of you from this area may recognize a young man and by a superstar from the University of Maryland who was also drafted to the Boston Celtics and died tragically while celebrating in 1986 in Maryland. But most of the sudden cardiac death in athletes are not among people that are famous like that. As you see from this graph here, most of them occur actually in high school students who are unheard of in terms of names. The vast majority is from cardiac arrhythmias, with less common causes of pediatric sudden death due to other types of heart disease besides rhythm disorders, neurologic or neurovascular abnormalities such as unrecognized brain aneurysms, pulmonary diseases including status asthmaticus and anaphylaxis, and drug toxicities. This is a rare event with about 10 per million students. Again, as I mentioned, the vast majority is due to cardiac disease. The vast majority occurs during sports. The vast majority occur in the presence of a teacher or a coach. And unfortunately, most of them are not successfully resuscitated on the. So we talk a lot about screening for these diseases. So what are we actually screening for? We're screening mainly for arrhythmia vulnerability. And we'll talk a little bit about long QT syndrome and Wolff-Parkinson-White syndrome and some of the other less common arrhythmias. We're screening for cardiomyopathies, coronary artery abnormalities, not artery disease, but congenital abnormalities, and unrecognized congenital heart disease. Things like long QT and Brugada syndrome, WPW, congenital heart block, there's cardiomyopathies, there's hypertrophic, rhythmogenic, and dilated, and we're going to get into each of those, and we'll talk a little bit about coronary abnormalities. What are we screening with? We're mainly screening with the history and physical. There are some helpful pre-participation forms for you to use in primary care offices, and then if they come to us, we may, or even if they don't come to us, sometimes people with ECG, cardiograms, and more to try to identify these patients who are vulnerable before diagnosis. Here's one example of a pre-participation form. It's got a broad checklist, a yes-no checklist, and from a cardiac standpoint, most of those revolve around have you ever passed out or nearly passed out during or after exercise? Have you ever had discomfort during exercise? Does your heart race or skip beats during exercise? Doctor ever ordered a test for you, such as an ECG, family history? Those are the main issues that are being asked. And if there's a yes to any of those, again, the symptoms are all exertional symptoms. Because if you ask if you've ever almost passed out or had chest pain or if your heart skips beats, almost everybody has that. Here's a nice pie chart of the causes of sudden death in young individuals, and you can see a broad range of things, but the biggest parts of those pie include hypertrophic cardiomyopathy, commotio cordis, which is getting hit in the chest, and coronary anomalies. Again, So different in older young adults. So it's by age 35, the vast majority of sudden death is coronary heart disease, even at age 35, people in their 60s. Whereas under 35, the majority is due to hypertrophic cardiomyopathy and only 10% due to coronary heart disease as compared to 80% in. These, as I mentioned, have disproportionately make the press. There's lots of different newspaper articles about individual people, children who are found dead during sports or collapsed during sports and usually are not resuscitated. Wide range of ages, usually teenagers, usually during sports. All kinds of these. I can keep going through and through these, unfortunately. And most of the time, there's no known pre-existing condition, and it's identified at autopsy. But let's put this in context. This is a rare event, as I keep saying. This is the incidence per 100,000 patient years. And you look at sudden cardiac death after age 64, 1,000 per 100,000. Look at sudden cardiac death in school systems with exercise. It's a fraction of 1. Well, in comparison to adults or in injuries, suicide, and homicide in adolescents. And injury, much more of an issue. But this is what we're focused on for the next half an hour. And so let's talk about these causes of sudden cardiac death in young patients. I mentioned the biggest difference between adults and children is that most kids don't get coronary artery disease, at least enough to cause plaque buildup and obstruction, causing myocardial infarction of the coronary arteries or ventricular tachycardia. So most pediatric ventricular tachycardia is non-ischemic. I found this bottle when I was in New Orleans recently. I still haven't tasted it yet. It looks pretty dangerous, but sudden death sauce may be risky. But there's other stimulants that are out there, both legal and illegal, and kids are using these stimulants. And for the most part, this is something that may cause risk of arrhythmias and sudden death, and particularly in those children who have unidentified vulnerability syndromes. And so even things like caffeine, nicotine, and more potent stimulants can provoke arrhythmias. In a recent local newspaper article about a here who basically overdosed on one of the energy drinks and had an arrhythmic sudden death. Some of the causes, as I mentioned, the most common cause is hypertrophic cardiomyopathy. And this is a disease of the cardiac sarcomere, the muscle protein here that causes hypertrophy, particularly of the septum. Myocyte disarray, you see some fibrosis and disarray, thickening here, ventricular arrhythmias, and it's due to mutations in genes that are called the sarcomere, so myosin and actin and troponin, those types of genes. And there are risk stratifications where the thicker the wall is, the thicker the left ventricular wall is, the higher the risk of sudden death. And so ways to stratify those patients to see who should be protected. And dilated cardiomyopathy, similar to hypertrophic, is a spectrum of genetic disorders with overlapping phenotypes. But typically, you get a dilated dysfunctional ventricle with arrhythmias and congestive heart failure. Another type that's being more frequently recognized, much more common in people of Italian, Greek, or Mediterranean descent, is something called arrhythmogenic ventricular cardiomyopathy, or dysphagia. It is a constellation of ventricular arrhythmias and sudden cardiac death in young people, usually not children, but maybe ages 15 to 40. And on autopsy or histology, you see fibrofatty infiltration of the right ventricle, as seen in this autopsy specimen. It's inherited in an autosomal dominant pattern, so family history, more common in males, however, exacerbated by exercise. Good friends Wolf, Parkinson, and White here in their monogram shirt. We see WPW quite commonly in teenagers, but the vast majority just have SVT, which is less malignant but more common. And sudden death is more of a concern with patients who are at risk for pre-excited atrial fibrillation. So if you have an accessory pathway, such as WPW, and then get AFib, that can conduct very rapidly as compared to those patients who have AFib without an accessory pathway, and they have the AV node to protect them to limit the ventricular rate. But if you have an accessory pathway, the ventricular rate can be very fast, and that's why children with WPW are at risk for sudden cardiac death. Marfan Syndrome, another disease that can be screened for, and again, an inherited condition where the cardiac manifestations are mitral valve prolapse and a dilated aortic root. And these patients die from either aortic aneurysms or ventricular arrhythmias, and they're prone to both. And so, obviously, you're more commonly going to see the skeletal and collagen manifestations in those patients that come to your office, and we will identify the cardiac manifestations. Not going to get too much into congenital heart disease, because that's really a completely separate talk, but patients that have obstructive lesions, cyanotic lesions, heart failure, scars on the heart are at risk for sudden death. But those patients are usually pre-identified. You already know whether a patient has structural congenital heart disease. You know they're at higher risk than your average student who's just coming in and wants to be cleared for sports. Coronary artery abnormalities, on the other hand, may have very little in the way of identification or symptoms. Here's just a diagram to show you what we're talking about. This is the normal distribution. If you're looking down from the head, down on the aorta, you'll see the left main coronary artery that comes off of the left cusp and then splits or bifurcates into the left anterior descending and left circumflex, and then the right coronary comes off of the right cusp. That's the normal distribution pattern, but there are children and adults that have the right coronary coming off the left cusp or the left coronary coming off the right cusp. It used to be thought that the left off of the right was more concerning, but more recent data shows that either one puts you at risk for sudden death with exercise. Typically, as you see from, this is just shown diagrammatically, but you can see that as the blood pressure goes up with exercise and the pressure in the aorta and the pulmonary artery go up, that coronary can get squashed in between the two and have insufficient coronary blood flow, which can lead to ischemia or myocardial infarction, whether it's the right coronary or the left coronary. And it's relatively common abnormality, often picked up incidentally. So you, as physicians and primary caretakers, have a much harder challenge than the cardiologist, because a lot that needs to be done to identify these rare patients. And I put a small font with lots of words up here, really to highlight the fact that there's lots that needs to be done, but to distillate it into bullet points, really history, looking for pertinent symptoms, particularly symptoms during exercise. We see so many children with sharp chest pains that's not concerning, or palpitations that aren't that concerning, or but if it happens with exercise, we worry more. I'm going to ask them about certain drugs, prescription stimulants, over the health supplements that they not tell you about unless you ask if they're using them for bodybuilding. Family history is important, since many of these arrhythmic disorders are inherited. And unfortunately, there's not much you're going to find on a physical exam for arrhythmias. Most of the physical is essentially normal, other than perhaps Marfan Syndrome. That referring probably for exercise-associated symptoms or more serious-sounding symptoms at rest, or suspicious looking at family history or other potential risk factors. And there's a variety of tests that we can choose from. We try to be as selective and not ordering every test on every patient. Stratify them. Most of them do get an ECG, and then depending on the frequency and the type of their complaints, whether they get imaging with echocardiogram or cardiac MRI, we're capturing the rhythm with either an exercise test or a Holter monitor if it's happening every day. Recorders. Infrequent that we need to do any of these other tests. And we are trying to find essentially a needle in a haystack. That's what you're trying to find, because most children with these symptoms, such as syncope, are usually benign conditions. So things that can be done, before deciding whether they need to be seen by a cardiologist is dietary history, or they eating disorder, orthostatic vital signs. If their heart rate goes up 30 points, or their blood pressure plummets when you go from lying to standing, that's pretty diagnostic, and you can treat them with fluids and salt, and they don't need a cardiology consult to change their diet. If not, then we may do, as I said, some other monitoring procedures, particularly ECG. You see, this is a frequency of syncope by age, and you can see a huge spike in the teenage years, particularly in females. Here in the triangles are females, and the circles are males. So both peak, but really females between 10 and 22 really peak in their incidence of syncope. And then as your orthostatic function starts to deteriorate in the elderly, they're also more at risk of syncope, older patients as well. What we worry about when we see these children with syncope, and once you refer to us, this is what we feel obligated to rule out, is congenital long QT syndrome. One of the inherited arrhythmias that's the most common, occurs in about 1 in 2,000 or 2,500 people, and we want to make sure we can rule that out when possible. The history, family history, exercise history, dietary history, and drug history. So again, most of this is history, nothing on the physical, and it's not that common you get such an obvious ECG. The one I'm showing on this screen has a QTC of 600, so this is obviously malignant, abnormal. The challenge is on some of the less obvious. Here, there's showing several different types of congenital long QT syndrome. The one we see the most commonly is called Romano-Ward. That's the autosomal dominant kind. Unwritten at the top, Gervais and Lang-Nielsen syndrome, associated with congenital sensory neural hearing loss, bilateral hearing loss. It's common and typically easier to pick up earlier in childhood when you identify this. And acquired causes of QT prolongation, the most common ones are due to metabolic disturbance, anorexia, bulimia, or taking certain medications, either diuretics or other drugs that prolong the QT interval. Again, a whole separate topic, but macrolide antibiotics such as erythromycin, zithromax, that will prolong the QT interval a little bit. Some of the antibiotic medications and some of the older antidepressants, the tricyclics. The biggest challenge is shown in this slide is the overlap of the QT interval, where we know that patients with long QT syndrome can sometimes have an entirely normal ECG, and we know that some patients without long QT syndrome can sometimes have QT prolongation at times, and it can vary by day-to-day, physician, fever, and health. And things. The challenge is QT or not QT. That's the question, to paraphrase Shakespeare. And it's not just the QT interval, but looking at family history, symptoms, and some of the other ECG findings, such as the abnormalities on the T waves and things like that. We can use provocative testing, which is mostly stress tests at this point, to try to provoke QT prolongation. Or genetic identification is quite good right now with a sensitivity about 5%. So people with long QT syndrome, about 75% of the genes are now identified by genetic testing. The main downside is the expense. do that, although many of the insurance companies have negotiated steep discounts, and sometimes patients only have to pay 100 and a few. There's about 400, 500 mutations in over a dozen genes. I made this cute drawing of eggs showing the different, the dozen mutations, but I have to hatch some new eggs because there's now more than 12 known mutations. But 90% of the known mutations are in these three genes. 2 potassium genes shown here and 1 sodium channel gene account for the vast majority of known long QT syndrome. Others are all single percentages. Some of the other arrhythmias that we see less frequently than long QT include Brugada syndrome. This typically occurs in the teenage or young adult years with intermittent right bundle branch block and ST stagnation due to a sodium channel mutation, and again is associated with sudden arrhythmic death and inherited in an autosomal dominant pattern, so you get a family history. CPVT, or catecholaminergic polymorphic VT, usually presents early, presents in childhood, usually in the first decade of life or before age 15, and is similar to long QT syndrome in how it presents with exertional or stress-induced syncope and ventricular tachycardia, but the QT interval is completely normal. And this is due to mutations in calcium handling genes. And I'll show a slide on that in a second. And then short QT syndrome is the same presentation as long QT and the same genes, except the QT interval is short rather than long, but can still lead to arrhythmia. This is the scariest ECG here. It's completely normal. Normal heart rate, normal intervals, normal voltages, a completely normal ECG for age. You put this child on a treadmill. This is what she looks like with polymorphic ventricular tachycardia and really an ugly looking ECG. And I want to stress the importance that this will be missed by standard ECG screening because those ECGs are done at rest. And this is CPVT. Short QT syndrome, as I said before, QTC less than 320 milliseconds, a very short QT. You don't see any space between the QRS and the T wave. This is a very rare condition. I think there's more papers on it than patients, and not something that we really are screening for, other than if you get an ECG. Commotio cordis, going to the next topic. This is not inherited, but this is one of the more common causes of sudden cardiac death during sports, and it's due usually following a blunt chest impact. Hockey puck or baseball to the chest or something like that, and then they're usually fine. They may lose their breath for a few seconds, and then within a minute, usually 30 seconds to 2 minutes after impact, they collapse, and almost always are not resuscitatable. Unless there's an AED immediately there, usually if you wait minutes, late, and this has very high mortality and is tragic and is really difficult to prevent. Not thought that they are susceptible, it's just thought to be bad timing and that they get the chest wall impact right on the onset of the T wave, sort of the vulnerable time period. And so it's really the epitome of bad timing. They get hit in the chest in the wrong place at the wrong time and cause ventricular fibrillation. The piglet model, this is not a human, but we looked at this 2 decades ago. There was a fellow with me, and we tested in piglets, and then got these baseballs as piglets in the lab. They were anesthetized, so don't stand out there. They weren't feeling any pain. But we looked at different hardness of baseballs, of Little League balls, and showed that the harder the ball, the more likely to induce ventricular fibrillation when impact was at that timing. These very soft baseballs, none of the kids like to use them. It would be fishy, the grip, RIF. Regulation balls are pretty hard. You've never gotten hit anywhere. They hurt. But you have to really soften the ball to the point where the players don't like them. make a significant impact in the decreased risk of arrhythmia from getting hit in the chest. These medium soft baseballs, like are used in Little League, aren't statistically different than a regulation. There's been a lot out there on how do we screen for this? How do we reduce the risk to our young competitive athletes and try to identify those who are vulnerable before they collapse on the field? And in the U.S., we've been pretty adamant, most experts are adamant that pre-participation screening, family and personal history, and a physical exam by the pediatrician caretaker without additional testing. In Italy, for example, everybody gets a 12-lead ECG. And if that ECG is negative along with the history and physical, they can be eligible for competitive sports. If the ECG is positive, they get sent to the cardiologist and get an echo, a stress test, a Holter, and then depending on what they find, a cardiac MRI, cath, angiograms, or ecology study in order to identify diagnosis of cardiovascular disease. And then those are ruled out, then they can play. And if this controversial paper showed that the athletes are in red and the non-athletes are in blue, and they showed that by instituting this program, they could decrease the rate of events in athletes down to where it is seen in non-athletes. The problem is this was a very high event rate to begin with, and the U.S. rate, even for athletes, is down around here, even without ECG screening. This came out in U.S. college athletes, a large number of college athletes who got pre-participation echocardiograms to decide whether to be cleared, and 99% of them were cleared based on the echo, where 11 of those 508 patients had some abnormality, relevant abnormalities on their echocardiogram. Only 3 of them, after further diagnostic testing, were restricted, and 505 of the 508 were eligible to participate in the athletics because they were relatively minor abnormalities that wouldn't preclude sports. Only 3 out of 500 were restricted after that. So what's the difference between Italy and the United States other than the pizza and the type of football versus soccer? The main difference is ethnic and racial heterogeneity that impacts the accuracy of the. There are genetic and phenotypic differences as well. In Italy, it's much more common to have arrhythmogenic right ventricular dysplasia due to the genetic pool there, versus in the U.S., hypertrophic cardiomyopathy is the most common cause of. The size of the population to be screened is also much different. There's 15 million athletes in the United States, and the cost of screening and the fact that we don't have single-payer health care makes this less enthusiastic and less of a value to screen every athlete with an ECG. And due to all of these issues, particularly the ethnic and racial heterogeneity, there's a high false positive rate in the U.S., which may lead to inappropriate disqualification, unnecessary additional testing with those associated costs, unnecessary anxiety in the family and the athlete, and a huge increase in physician manpower and other resources to be able to screen these 15 million athletes. Look at NFL football players and collegiate football players. Only 70% of African-American football players have a normal ECG. And so 30% are going to be abnormal and lead to additional testing, despite the fact that all of them have normal hearts. Recent study that came out in Israel that overlaid that Italian sports law. They decided to do screening because they had 1 year with a peak, probably coincidental peak, in the incidence of sudden death. And then the peak came back down to baseline. They instituted the sports law here where everybody got screened prior to sports and really saw no significant change at that point. So they did not feel that mandatory ECG screening of the athletes had any effect on the risk. Very controversial, continues to be controversial. There are groups here, they're often funded by parents of someone who's suffered through a tragedy, or other nonprofit healthcare organizations of student athletes. I've done them in the past. I've gone to high schools and been part of this mass screening of healthy students to see who needs something done. And the pre-participation screening questionnaires seem as good as doing ECGs on everybody else. The recent symposium at the National Blood Institute, led by John Kaltman from here, determined this and really showed that they were towards reducing sudden cardiac. No data that ECG. I want to make sure we have time for questions and answers, so I want to show a few slides on the treatment options. Once we identify an arrhythmia, an inherited arrhythmia, the mainstay of treatment are drugs, mainly beta blockers, beta-adrenergic blockers. If those don't work, there's a multitude of other ion channel blockers that we can use that block the calcium current, the sodium current, or the potassium current. All of them are poisonous, and so we try not to use those higher potency drugs unless absolutely necessary, and for most patients, beta blockers are effective. If it is a point that can be ablated, it's an arrhythmia that we can use catheter ablation. We're tending to do that more often at a lower threshold now, because in the old days, which is about 5 years ago, we used fluoroscopy, X-ray, to map the lesions. And nowadays, we're using three-dimensional, what's called electroanatomic map, which is similar to virtual reality combined with GPS. So it's sort of like your car, you see the catheter moving along in the heart, and tells us where to go. And, it says, for the lesions at dots, we don't dots in that, but it avoids X-ray completely in taking out one of the risk factors for catheter ablation. So we tend to do that now almost first line for things of SVT rather than being on medications. Pacemakers have come a long way since this crank-handled one where you had to move the crank to keep the power going. Now they're quite small, and children as young as a year of age can get a transvenous pacemaker, and smaller than that, pacemakers through other approaches. Implantable defibrillators, these are important for preventing sudden cardiac death, and they've also substantially come down in size. They can perform anti-tachycardia pacing to overdrive pace painlessly out of an arrhythmia. And then if that vulnerable patient requires a shock, the device can shock them out back into sinus rhythm. And, I sort of joke that it's the cardiologist in a box, because it's always just sitting there in their chest monitoring them. So they don't need to wear external Holter monitors. They don't need to wait for someone to bring an AED around. It's there, and as soon as they go into an arrhythmia, it'll watch, it'll detect, and really come down substantially in size so they can be put in small children. Speaking of AEDs, these are now all over the place. You see them in you all have them in your automatic as size, and they deliver, they monitor and look for a shockable heart rhythm and deliver defibrillation shock if needed. They're getting smaller and smaller. They're simple and automatic. There's a great study that came out in one of the journal articles showing how they taught fifth graders how to use them. 5 minutes the fifth graders could teach others and use them, placing the pads in the right places, shocking when you're supposed to and not shocking when you're not supposed to. Also come down in price, no longer need a prescription, and are often covered by readily available. Algorithms have been now demonstrated to be accurate in children. Some AEDs come with pediatric pads that are about half the size, and when those pediatric pads are plugged in to the AED software recognizes the smaller pads and delivers an attenuated output. So, 50 joules instead of 150 joules for the smaller patients. They have been safe, life-saving in any circumstances. 12-year-old swimmer is on QT, gets out of the pool, AED pad put on, recognizes ventricular fibrillation in an unconscious patient pulled from the bottom of the pool, and shocks her back into sinus. So, in summary, the treatment of cardiac emergencies, I think, be prepared. Your office staff should have CPR training, the equipment and staff there, remain strong. Emergency readiness, I would reverse the order and say phone is probably the most important emergency readiness piece of it. Call for help first, MS, and have a crash cart in your office with appropriate medication. Identify the problem, check the medical history if known and an unconscious. Utilize the AED. Put the pads on and they don't have a shockable rhythm, it will shock the patient. I actually used it on my wife once when she fainted on the floor, and when she woke up she was scared to have the pads on, but just something minor. So in summary, in cardiac evaluation of the pediatric athletes, we reviewed incidence and causes of sudden cardiac death, some of the diagnostic guidelines and screening recommendations, the referral guidelines for subspecialty referral to someone pathologist, some of the utility and the flaws and pitfalls of mass screening or other diagnostic testing. Take any questions. Thank you.